The continuation of positioning for the lumbar spine. For the AP axial L5S1 projection, you'll use an 8x10 lengthwise cassette with a 85 kVp and center cell technique, 40-inch SID. Your central ray will be angled cephalically, entering on the level of the ASIS and mid-sagittal plane. For male patients, you'll use a 30-degree angle, whereas for a female patient, you'll use a 35-degree angle. And this is due to the pelvis shape difference between men and women. Your respiration phase will be suspended. The patient will be supine with their legs flexed and supported with a sponge, similar to an AP lumbar. For the axial, it will demonstrate the L5S1 joint space as well as the sacroiliac joints. Indication of no rotation by the pedicles and the spinous process. So for AP side bending, the patient will be standing or supine using a 14x17 cassette lengthwise, 90 kVp in centered cell, 40-inch SID. Your central ray will be perpendicular to your image receptor. You will place your image receptor, the bottom edge, approximately 1 to 2 inches below the iliac crest. Your respiration phase will be suspended on expiration. For positioning, you will use the fulcrum of the pelvis as the flexing point. For the patient who is supine, you're going to have them reach towards the right and towards the left and take 2 different exposures, as well as for the patient who is standing, right and left side bending. The image will demonstrate the thoracic and lumbar vertebrae, including 1 to 2 inches of the iliac crest. The spinal column will be aligned parallel to the image receptor. You'll have open intervertebral joint spaces and an indication of no rotation. For the lateral flexion and extension, you'll use a 14x17 cassette, 95 kVp at center cell, 40-inch SID. Your central ray will be perpendicular to your image receptor and position like you did for the side bending. The bottom edge of your image receptor will be 1 to 2 inches below the iliac crest. The respiration phase will be suspended on expiration. Using the pelvis as your fulcrum of flex and extend, first draw the patient's legs up as far as possible for a fetal position for the flexion. For the extension, move the torso and legs posteriorly as far as the patient can go for the hyperextension of the long axis of the spine. On the radiograph, you'll have the thoracic and lumbar vertebrae, including the 1 to 2 inches of the iliac crest. The spinal column will be aligned parallel to the image receptor as indicated by the open intervertebral foramen and the open intervertebral disc spaces. Moving into the image analysis of the lumbar spine. Again, for an AP lumbar, you're going to have the spinous processes aligned to the midline of the spine. The sacrum and the coccyx will be centered in the inlet of the pelvis and aligned with the pubic symphysis. To identify rotation, the side that has the greater distance between the spinous process and the pedicle is the side closest to the image receptor. So we have the pedicles as identified nearly as the eye of the Scotty dog and the spinous process. So the patient was rotated towards the left side. For the patients whose legs were not positioned correctly, when the patient's legs are flexed, you're going to see the interspace between the T12 and L1 open, so thoracic 12 and lumbar 1 should be open. If the patient's legs are not flexed, that interspace will be closed. For an AP oblique lumbar, you're going to see the superior and inferior articular processes in profile. The zygapophyseal joints will be open, and the pedicles are midway between the vertebral body and the lateral border of the vertebral body as well. Right here is where the eye of the Scotty dog is the pedicle. All right, so if your patient is under-rotated, the zygapophyseal joints will be closed. The pedicle, or the eye of the Scotty dog, is closer to the lateral border. And the lamina, or the body of the Scotty dog, is going to be elongated. Now, if the patient was over-rotated, the zygapophyseal joint will be again closed. The pedicle is closer to the midline of the vertebral body, and the body of the Scotty dog, or the lamina, will be narrowed. It will be foreshortened. Now, for a lateral lumbar, you're going to see the intervertebral foramen clearly demonstrated. The spinous processes should be in profile. The most common error is the positioning of the patient with rotation anteriorly. And we can identify rotation is by looking posteriorly on the body of each vertebrae. And if you can see two outline of the posterior portion of the vertebral body, the patient is rotated. Now, if there is no sponge placed underneath the waist of the patient, we're going to actually see kind of a football shape of the vertebral bodies. We can see the bases of each vertebral body, as well as actually the top as well. It looks like a football. Now for the L5-S1, we want to see the intervertebral foramen clearly demonstrated. The greater sciatic notch and the pelvic wings should be superimposed. Now, the most common rotation again for the L5-S1 spot shot is that the patient is rotated too far anteriorly. We can see two of the sciatic notches, the greater one right here, as well as the other back here. That indicates that there is rotation, and the most common error is anterior rotation. With lateral flexion, meaning that there isn't a sponge underneath the patient's waist, we're going to see that football shape of the joint space again. References includes your textbook for positioning, your image analysis, and an additional resource that can be found in the library. It is the Merrill's Atlas for Radiographic Positioning and Procedures.